I'm recording. Okay. All right. So if you're in the Menti, give me a little like or a thumbs up or something. We'll probably only get through maybe half of this before we go ahead and we'll take our break. This honestly is one of my favorite things to talk about just because I think pre and post-op care is so interesting. It's definitely, did I say favorite? It's one of my favorite. I love diabetes. I think it's crazy interesting. And we get to do diabetes next term. It sounds weird too, like doing diabetes. We get to learn about diabetes. We don't all just become diabetic for a day. Although I think it would be super interesting to try to see what people's lives are like that have diabetes. Yeah, not fun. I think we'd have a lot more sympathy for our patients. Okay, moving on. All right, so most of us are here in the Menti. There we go. All right, so this is chapter 12, taking care of patients having surgery. So when we talk about surgery, there's a couple different levels. Like I think we think about surgery as kind of this thing and people go to the scary room and we cut them open, but we do it for different reasons. And there's also different urgency levels. So when we talk about urgency levels, we have these four types. So anybody can think of something that would be an emergency surgery. What kind of appendicitis?
It's about to rupture and like blow up.
Usually it's near rupture or ruptured appendicitis. Yeah. Oh, yeah. Acute bleed, acute trauma. All right, somebody got hit by something, the leg's hanging off. That's an emergency surgery, okay? What would be considered an urgent surgery?
Maybe like a break of a bone sometimes.
Yeah, so if it's a bone break, but it's not, it's something that we can wait, usually 24 to 48 hours, we can wait a little bit longer.
And if they break their tooth, I think they do have to go into urgent surgery. I remember like we took an x-ray of a kiddo and like they probably most likely have to do surgery on a tooth.
Yeah, so if you look at somebody and you look at them and you go, you know, if they're walking into like maybe the emergency room and you're thinking, good Lord, like you want to move them right to the ER, or if you go, ooh, I don't like that, right? Like it's kind of a appendicitis, but it's not super inflamed yet. It's not near rupture. That could be urgent, right? We need to take care of it, but it's not so urgent. Somebody who's got gallstones, they need to have their gallbladder taken out. Different things can be urgent, but it's not it's not usually we say emergency, that's life threatening. Something that if we don't take care of it right away, it could kill them. Ectopic pregnancy would probably be emergent. Yeah. If there was an internal bleed somewhere, yes, that would be urgent because we're, you know, something's going on. We've got to go in and fix it. Or that would be emergent. Yeah.
Nice.
No. I thought you said emergent and then my brain caught up with what you said. Yeah. So yeah, anything where we're threatening, they call it threatening of life or limb, meaning their life, they might die, or if we don't go in right away for surgery, they might lose their arm or leg because we didn't go ahead and have surgery. Urgent, we have 24 to 48 hours to kind of fix them, see what's going on. We'll talk about kind of a little bit with this in a minute too. What would be an elective surgery? Yeah, deviated septum. If somebody can't breathe very well, because their septum is kind of deviated. Yeah.
Something within like a specialty clinic where like this is specialist, but people can get it on a weekend.
Not aesthetic, but I like what you're thinking with like a specialty office, right? So somebody like a pediatric, a kid who has a lot of ear infections, they might want to have tubes put in their ears, right? That's elective. It's medically, it's indicated, right? It's for a good reason, but it's not emergent or urgent. Or think about our hip replacements or our knee replacements. Those are for medical reason, but it's not something that's gonna, you know, we have to do right away. So that's elective. We're opting to do it. That's something that's medically good reason, but we're saying, yes, we're doing this. We want to. Optional, that's where we get to the aesthetic things, where if we want to maybe do a rhinoplasty, not because of our nose had trauma and we need to fix it, but it's because we don't like how it looks. Or breast augmentation, or there's all kinds of other surgeries that are elective. They're not medically indicated at all, but you could choose to do them. Those are, or not elective, those are optional. Sorry, not elective, optional, optional, totally optional. All right, so then we talk about our purposes of surgery, right? So aesthetic, how we look, right? And that might, it kind of overlaps a little bit, because if you have a deviated septum, it might look a little funny. My son, who's like my perpetual case study, you'll hear a lot more about him in the fall. He's got a little deviated septum, and we just took his passport picture, and he was like, "Mom, do I really look like that?" Because his nose, it looks like he's facing this way, and his nose is like going that way. Like, but fun fact for kids, they have to be, I think it's either 16 or 17. I think it was 16 before they'll fix the deviated septum. It happened years ago because they want their face structure to grow and mature and kind of get more set before they go in and fix it. So we have an appointment next week to see a person to go fix it. Okay, another purpose, diagnostic, right? Maybe we're like, oh, I think this person might have some tumors in here, or, you know, there's something going on in their belly. We need to do a diagnostic surgery to go in and see what's happening. Same thing, exploratory is more of like, we're not sure what's going on. Diagnostic is where they might be taking tumor samples, so maybe like actually biopsying things. Preventative, what would be preventative? Oh, that's kind of a good one. Yeah, preventative would be wisdom teeth, right? Because if it's starting to show like there's some impaction and that might eventually cause issue, we want to go ahead and take those out. Curative. Yeah, usually removing a tumor. So I think a lot about like people who have breast cancer, you know, you might want to remove that breast. You know, they're probably still going to have treatments afterwards, but that's a curative surgery. We want to get rid of that cancer.
Would it also be like a limb, if like you have to amputate something because of?
I think
that
you could probably
infection?
consider a limb amputation curative. Yeah. Reconstructive. So just to follow the same thing, somebody who has a breast removal, they usually will come back after the removal and then have reconstructive surgery afterward. And then there's palliative. And that's where somebody usually, oftentimes with cancer or other long-term diseases, where it's causing issues with them, you know, but they might kind of go in and remove a lot of the tumor or something, especially if it's pushing in on other areas and causing other issues. It's not going to cure the disease or the cancer, but it's going to help their life be a little more comfortable and just make their, you know, whatever life they have left better. So types of surgery. So I know we're going through all these definitions. I just think it's interesting. So we often think of open incision, right? We think about you're laid out on the table and they slice you open and they dig in your guts, or maybe on your leg or wherever. And there are surgeries where they do make an incision, open up, and that's one type of surgery. But there's also what we're moving to more and more is this minimally invasive surgery. If at all possible, they're going to make little, I call them poke holes, and just go in usually with a camera and tools, and then they fix whatever needs to be fixed in. So I think a lot about appendectomy, right? Your appendix is inflamed or it bursts. They'll go in through your umbilicus, your belly button. That's kind of the bigger incision. And then they have a couple of poke holes on the side for their instruments. And then they kind of, and it's amazing. They blow up your abdomen with medical gases. So the bellies kind of go, so they can see a little bit more. And then they go through with their instruments and they take out the appendix, right? Sometimes there have been issues where they're like, ugh, this is a little more involved and we have to maybe now do an open incision because there is more things happening and we have to go fix it that way. They do, yeah. That's usually why the belly button already is a scar, right? Because what is your belly button from? It's from your umbilical cord. It's actually your belly button's a scar from where your umbilical cord detached. So they usually will do a little incision right above your belly button because it's usually hidden pretty well when they do those types of surgeries. They might do, it's called robotic surgery. So a lot of the like total hip surgeries that they're doing now, they do with a robot, which isn't like a robot in the room helping the surgeon. The robot is just this machine, and it's more of, so like for the hip surgeries, the robot, it attaches, it looks at this, like maybe this is the bad hip, and the robot will attach to the good hip and actually map out what it should be. And it assists the doctor as he's doing things to show him like, okay, we should have this angle, we should have this, we should go in at this, that. Anyway, it really helps to be more precise and have better outcomes. But it's a different, when we say robot assisted, like a lot of patients are like, well, why are we paying the doctor? And then there's laser surgery too. So I think about patients that have kidney stones. They might go in with a scope up into the ureters and use a laser and try to like break apart some of those kidney stones that are there. This is kind of an old example of a robot, but I do kind of like that it shows there's different robotic arms and things that it can control. Again, a lot of the things in our textbook, the textbook is really newly updated, but some of the pictures I feel like they kind of pulled from a while back. Anyway, so when we talk about surgery, patient's going to have surgery, we want to make sure we do something called rehabilitation. Like we talk about after surgery, rehabilitation and like getting them back up to good functioning. But if somebody's really sick and they're not doing too well managing their medical, care, or they're just not doing well overall, surgery is only going to like make things worse. So we rehabilitate them. We try to get everything as well functioning as possible. And so sometimes that might be patient, like doctor saying, hey, for you to go in and have this surgery, I need you to quit smoking. I need you to lose a little bit of weight. I need you to get your blood pressure in a healthy range because I know, and it might not be all three of those things, it might be any one of those things. But we know there's certain things, if we can do them or get our patients to do them, it's going to increase their positive outcome after surgery. They're going to do better. So things that might affect your surgical outcome. And what does that mean by surgical outcome? Yeah, how you do, right? Will you make it off the table? Or will you will you be functional a month after or a year after? So how old you are, your age, what does that mean? Right, and it might be younger people as well. When I think about babies or neonates or newborns, sometimes their age, they're too young. We need to let them kind of develop a little bit so they're strong enough to have surgery. So whenever we say age, most of the time we're talking about opposite ends of the spectrum, are very old and are very young. Those two populations are usually most at risk. If you have chronic disease, that really can put, anybody at risk. Emotional responses, right? If somebody is just terrified all the time of the doctor and whatnot, there's a lot of stress responses our body has. And we might want to see if we can help them control those because, if they're going to have surgery, that's going to be a lot of stress on their body. Their nutrition for this, especially the elderly, right? They don't eat a lot of protein. One of the things, a surgeon that I work with that does a lot of the total joint replacements, he has all of his patients, like once they're prehabilitated, the week before surgery, he has them drinking these nutrition drinks twice a day. And they have a lot of good carbohydrates and they have a lot of protein in them because people that have a better diet, they have all these nutrition they need, are going to do better after surgery. He then has them take them after surgery as well. A lot of people are like, these are so gross. And, I'm like, oh, sorry, but it does help them. And we also really want to have them avoid smoking, alcohol and drug use, because we know those all have a negative effect on our body. All right, so get into our first question. Which of these would the nurse state to describe the post-operative phase of surgery to the patient during preoperative teaching? So if we're teaching somebody about surgery, how do we describe post-operative? Let's see. Oh. There we go. All right, good job, you guys. So when we talk about post-operative, it's admission to the PACU. PACU stands for peri-anesthesia care units. thank you, post anesthesia care unit, through recovery when they're finished being recovered. So preoperative, that's when you decide to have surgery until you go into surgery. So preoperative could be, you're in the doctor's office, just use the hip example. You go in because you have this hip that needs to get replaced. From the time you go in to see the doctor and talk to him about surgery until the weeks or months following, until you actually have surgery, that's all preoperative, right? Intraoperative, that's when you are in the surgery itself, you're in the operating room. And then postoperative is everything after the surgery. Typically, your postoperative time ends once you're either discharged from the surgery center or the hospital or wherever you went to, and then you're just in like a recovery mode. So what is our role when we're looking at these patients that they're coming in for surgery or they're getting ready for surgery? What are we responsible for? Well, we want to do a lot of data collection. We'll talk about more specifics with that, but we really want to reinforce teaching and instructions. Because patients for surgery, we're going to talk about anesthesia in a minute. Anesthesia makes people forget. So if we're trying to get all of our teaching done after, how much are they going to remember? Not much at all. So to the best of our ability, we want to do a lot of teaching before they go into surgery, even like before the day of the surgery. So a lot of times, you know, you have people meeting with nurses, that you might have a patient who you have to go, hey, let's talk about some of the things after surgery. I want to teach you how to do, like, let's talk about your dressing changes. Let's talk about different exercises. Let's talk about the incentive spirometer, all those things that are really important so that they can remember them afterwards. We're also going to talk about family care too, right? Because we know anytime we take care of patients, especially with surgeries, there's usually family involved. And so they're also part of that care that we have to give. A lot of patients have very emotional responses to surgery. A lot of patients are afraid of dying, right? There's a lot of patients are just afraid of anesthesia specifically because they're afraid that they're going to go to sleep and not wake up. And so that's a valid concern, right? There are people who have died in the operating room. You know, depending on what's happening with them, it might not be a valid concern, right? If they're getting a bunion fixed on their toe and they're healthy, it maybe is a very low risk that something could happen with them. You know, if they're going in for a heart transplant, that might be a surgery that they very well could, you know, pass away during it because it's a very high risk surgery. Patients are also, they're also usually worried about intraoperative awareness, meaning waking up during surgery. Everybody's heard stories about people waking up, or they hear people talking, or I remember the music that was playing. I will say in my experience, when I've ever been in an operating room, people have always been very respectful, looked out for patients. It's not been anything inappropriate. And so I'm thankful for that. Because I think I would be really afraid too if I like woke up from surgery and people were talking bad about me or something, or I don't know, like look at her toenails. I don't know. People are also afraid of pain, right? Because usually whatever surgery we're doing, it's gonna hurt. Occasionally patients have come in and I'll say, you know, hey, after surgery, you know, we like to talk about pain. We use this pain scale. When you go home, like, where would you like to be on that pain scale? And I had patients tell me, they go 0. I don't want to have any pain. The doctor said he's going to fix it and that you're going to give me medicine. And then it's like, oh, okay, well, clearly we didn't do enough teaching beforehand because surgery is going to hurt. And we want to, and not to scare patients, but to prepare them to say, no, you know, it's going to be painful, but we are going to do things to treat that pain. And really what I always say to my patients, and feel free to use this or not use it, I say, I don't really care what that number is. I want to know, are you hurting or are you comfortable? And if you're hurting, I want to make sure that number goes down. Because if you're hurting and you tell me that number is going up, it means what we're doing isn't working and we need to try something else. And I think sometimes that helps my patients because they feel like I've got to say 10 to get pain medicine, or I've got to, you know, I've got to prove that I'm hurting. And I want to establish a rapport so that my patients know, no, we're a team. We're going to work on this together. All right. I don't want to do this. Okay, moving forward. We talked about the Okay, so pre-admission. So let's say you might work in a pre-admission clinic. You might have where you have to get patients ready for surgery, meaning you're doing a lot of these things. We're going to be going over their health histories. We're going to identify what might be some risk factors. If a patient comes in for their hip surgery, are they a smoker? Do they drink a lot? What are those things that might make them higher risk? We're going to be evaluating for that. We're going to also look at, first of all, when we say education, I think a lot of times we think, what are we educating them? Part of our plan is we want to find out what's their educational level, right? We want to know, first of all, can our patients read? They, you know, because if they can't read and we give them a big written, beautiful handout with all the information they want to know, that might not be helpful. Or on that same thing, a lot of people maybe couldn't speak English okay, but not read it, right? What is their native language? What language can they read in? Because that's how we want to make sure we provide information for them so it's accessible. We want to talk about discharge planning, right? After surgery, you're going to go home maybe the same day. Who's going to be there with you? Nobody. That might not be safe, right? So we want to make sure we have a plan for surgery. Any referrals, you know, they need to go to PT and OT afterwards, or maybe if they've got a lot of cardiac issues, they might need to go see a cardiologist, a heart doctor first, to make sure there's nothing else we need to do to make them optimized or ready for surgery. Some diagnostic tests, I think specifically pregnancy test. If you have not been through menopause, or if you still, I used to tell people, if you still have a uterus, then you are getting a pregnancy test. And it's funny, so many people get very offended sometimes, and they're like, oh, I haven't had sex in 10 years.
Yeah.
And then fortunately, I work at St. Clair, and so I'm like, listen, it's a Catholic organization, they believe in immaculate conception, so everybody has to do this. And so then usually people are like, okay, like, but I mean, really, we want to test everybody for pregnancy, because if somebody is pregnant and we're doing surgery on them, we're giving them a lot of medications that might not always be safe for the baby. Right? And so if we know they're pregnant, we might change maybe some of the medications we give them. Maybe if they came in to get their toe fixed and they find out they're pregnant, maybe we can wait until after the pregnancy is done, right? We don't need to expose that, that baby. And then we also talk about advanced directive. What's an advanced directive? It's in case they die, or it makes medical decisions, right? Or we're talking about medical decisions. Advanced directives for medical care, they're talking about if you can't make a decision, what do you want done? Or if you can't tell us, right? What are some things we want to have on that advanced directive? A DNR is part of it. What's that? A proxy, yeah, like who you want to make decisions for you if you can't make decisions. You know, there's some advanced directives that go very in depth and they talk about, you know, if you're on a ventilator for a long time, do you want to feed them too, or do you not? Like it can go very in depth, or it could just be, you know, DNR. If your heart stops beating and you stop breathing, do you want us to do something or not? Usually we want to have a very specific conversation saying in surgery, make them stop breathing because we want to control it, you know, so outside of the surgery setting, you know, what do you want us to do? And then especially when patients are going in for surgery where we're putting them to sleep, we want to make sure they have a proxy. They have a loved one or somebody that they designated that they say, if I'm out, I want, you know, Joe in the chair over there to make decisions for me. And hopefully I've had discussions with Joe in the chair to say, hey, you know, if this happens, this is what, you know, they hopefully have that conversation. Unfortunately, that doesn't always happen, but at least that person has appointed them. Okay, so when we're teaching, so we're back in our clinic, we're getting patients ready for surgery. We're going to talk to them about preoperative routines. And what that means is, hey, this is the day and time of your surgery. We also want to talk about length of stay. You know, is it something you're going to go home that same day? Or do you maybe need to stay for a couple of days in the hospital or wherever? We want to talk about items to bring and what to wear. I always want people to wear the most cozy, like, you know, comfortable clothing possible. It drives me crazy when people come in for like, I don't know, some surgery that just, and then they have these fancy clothes with all the buttons to put on. And I'm like, oh, can I send you home in a gown? Anyway, so I want to talk about like what to wear or anything they need to bring. You know, sometimes if patients have sleep apnea and they wear a CPAP, we tell them to bring that, right? Because you're going to be sleeping after surgery in the recovery room and probably a little bit, especially if they have to stay overnight. Yeah, please bring your CPAP. We want you breathing at night. Recovery after surgery. Want to make sure patients understand. You know, hey, you talk to the doctor about your recovery, but you know, just want to make sure you know you're probably going to be out of work a couple weeks, and this is what it might look like. Making sure they understand that. And then family information, who's family, who's going to be with you, who's going to be able to be contact. And then making sure we have a responsible person to send them home with. Ooh, okay. So now that we just talked about it, which of these is a role that you would have in a preoperative phase? Select, hopefully it's select all that apply. We'll see if it'll let you. It is not, okay, we'll just choose your own adventure then. All right, after we answer this one, I think we should go on a short break. All right, and ready? I cut us off. All right, so yes, assist with data collection, you know, find out what we need to know from that patient. We want to reinforce teaching, provide emotional support, and we want to make sure we include the families. We don't develop the care, even though, or the plan of care. We're enacting the plan of care, we're carrying it out, but we're not developing it. And provide informed consent. We'll talk about that in a minute. Who provides the informed consent? Yeah, whoever's doing the procedure itself, they're the ones that need to provide informed consent, which means they explain the procedure, they explain the risks, the benefits, all of that. Okay, let's take a short break. Let's come back at a quarter after. So 9:15. Yeah. Oh, yeah, and that's, we're gonna talk about that. Yeah, so the good thing is just ensuring that the provider has spoken to the patient and that the patient.
I think that's good. But they're not gonna put-
Witnessing it,
not like,
giving it, yeah, so it's just, it's a matter of like the definition. But also like. Giving informed consent, like that's what the provider has. And the weird is that that's a good thing. Or confirming. Yeah, you wouldn't witness it from a patient, like, yes, with all my questions. But part of it is that is that. Yes, always different. Then usually you have two nurses, and you can just say for both patients, and two nurses that come in, both confirm, and then you just say patient unable to write. And then the two nurses. Yeah, I know. Yeah, that's a really good question. I don't know if I even have that on my slide. I probably should add that on there. There we go. All right, so going back to the LPN's role, what we're doing, we're talking through a lot of things with our patients to make sure they understand. So one thing is so important. Like if we have to have any prep beforehand, like if they're gonna have bowel surgery, they might have to take an enema at home beforehand. Medications. There's some medicines like beta blockers, they're actually cardioprotective. They're really good for you to take before surgery. So we want them to take before surgery. What would be a medicine that we don't want somebody to take before surgery? A blood thinner, right? Because we know they're gonna just bleed more. That would be counteractive, like not very good. Also, NPO criteria times, because you need to have an empty belly for surgery. Because you might, yeah, you might throw up and aspirate, not good. Usually they want you to have an empty belly for about 8 to 12 hours, depending on whatever surgeon or where you're at, what that's the preference. Now, we talked about the emergency levels. So if somebody is having an emergency surgery, they might have eaten within that time. You just have to deal with that being a risk, and walking into it, because especially emergency, they might die or something, they might lose a limb if we don't do that surgery.
So do they have? Is this like strictly just monitoring for aspiration then?
They always would have an anesthesiologist with them, or a CRNA, like somebody that's anesthesia, and their whole thing is sedation and airway.
But an LPN wouldn't be delegated.
Oh, no, the anesthesia provider just knows that's probably risk. They might have they might do a few more things or choose certain anesthetic agents that are less likely to cause, nausea and things like that.
That would just be a scary.
Yeah, that would never be on you to do. Yeah, but good question. With the NPO times, it's really important that we teach them, right? Because if you have surgery first thing in the morning, you probably aren't going to eat or drink after midnight usually. But if your surgery isn't scheduled till like 4 o'clock in the evening, you can usually have breakfast, have some clear liquids up until a certain time. And we generally want them to, because otherwise, if they stop eating and drinking and they're all day, they're gonna come to us dehydrated. And then good luck getting an IV started on them. And then they're gonna feel crummy, which is gonna make them less, likely to do well during surgery. We also want to teach some post-operative exercises, right? Some deep breathing and coughing. So before we had incentive spirometer, we did a lot of deep breathing, coughing. Anybody can show me what that looks like? That was close. So you think about, take a deep breath, and then usually look to one side, and then like nice big cough, and another deep breath. Look to the other side. Good. I'm trying to like blew some things off of here. And looking to the side actually helps to clear one side of the lung and the other. I still teach patients to do this because they don't always have their incentive spirometer right with them, right? I'm like, okay, you go and maybe it's an older lady, you're sitting there to pee or poop, or while you got up after surgery, we'll take a minute to do some deep breathing and extra like coughing, maybe have to pee a little bit, I don't know. Anyway, we also want to teach them incentive spirometry, and we also want to teach them leg exercises. After surgery, you're not going to be walking around as normally you would. We want to make sure people are as mobile as possible, but we're also going to say, hey, if you're in bed, you're in the chair, you're laying there with your feet extended out, do some gas pedals, right? Move your legs around, do something to help encourage circulation. Because what are we preventing when we're doing that? Yeah, the blood's not going to be pooling and sitting there as much, and we're going to prevent blood clots from forming.
Are you doing the breathing exercise for like any surgery just because of the anesthesia? Or
because
like,
anesthesia, we want because yes, you're right. So the breathing and the incentive spirometer, it helps to clear anesthesia gases. So that if you use anesthesia, inhaled gases, it helps to clear them out. And after surgery, because of the sedation, patients aren't breathing as deeply. They're usually taking more shallow breaths. They're a lot more sleepy. And then if you think about the pain medicine we often give them after surgery, those have the same effects where they're more sleepy, they're not taking as deep breaths. So we want to encourage them to take those deep breaths to prevent pneumonia.
That's for like any surgery, ways to keep like even like smaller.
I would say like a wisdom tooth extraction or, probably not. But for most other things, and if somebody is like really healthy, they're a runner and they're in their 30s and they came in for whatever minor thing, I might teach them it, but I might say, until you're up to regular functioning, but then I also think about our little 90-year-old grandma that fell and broke her hip and now she's not going to be mobile and doing much for a while. I really want to make sure we prevent some things with her. So you want to use your critical thinking or clinical judgment about, who do I really need to make sure we hone in on this? Yeah. All right. So going back to consents. A nurse witnesses a consent with the understanding that which of these criteria apply. So I know it doesn't let you choose all of them, but just think about which ones you would choose. What does the informed consent apply? All right, and so yes, it gives legal permission for surgery. The informed consent is the physician or whoever's doing surgery, it's their responsibility to get that informed consent. However, we witness it, and we'll talk about the witnessing in a little bit. The patients cannot be sedated when giving informed consent, because if they are sedated and their mind is essentially altered, that's not a valid consent. We need to make sure they are clear and knowing what they're consenting to. Your guys are absolutely right. Consent it can be withdrawn. So if somebody signs a consent and all of a sudden they're like, no, 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 no. It's not like it's like too late, bud. Like you're going in. No, they can withdraw their consent and say no. It's voluntary. You do not have to consent, right? You can say, no, I don't want this surgery. And this, I left this in because F.A. Davis says it's valid for 3 months. It really depends on your facility policy. Oh, yeah. Oh, thank you. Yeah. Oh, yeah. Thank you. I'm like, where is it? So consents, typically you want to do surgery within 3 months, but especially with COVID and the pandemic, they were allowing consents to be much longer. And so now most places have changed their policy to say, you know what, as long as it's reasonable. And then that's kind of up to interpretation. But if you ever get an F.A. Davis question, you know, it's going to say 3 months. I will not have this on your final. All right, so talking about the consent, that's when the patient's giving that, like I said, legal consent for surgery. It's the physician's responsibility, and they can't have anything that's altering their mind. Now, if they take oxycodone every day for pain and they took their normal dose that morning, that's fine. But if the anesthesiologist came in and said, hey, you look really anxious, you want something to take the edge off? And then they're like, you know, then they're not consentable. They've had medicine that's making them altered. It can be withdrawn at any time. And again, that doesn't even make sense because it's the other F.A. Davis question that said 3 months. So it's valid for however long the facility policy says it's valid for. So our role, we want to make sure that the patient's been informed. There's going to be some times where I come in and I watch, maybe you guys are the doctor and the patient, and I watch you two talk about it. And the doctor might even say, oh yes, will you sign this? And I hear the whole conversation. There might be other times where I walk in the room and I say, okay, you're going to have surgery. I saw the doctor was here. I see this form, but he didn't have you sign it or she didn't have you sign it. You know, did they talk to you? I want to make sure the patient understands. Either way is fine. We just have to make sure the patient understands and their questions have been answered. One thing that's typically on consent forms as well is, does the patient consent to blood products? Because going into surgery, there's risk of bleeding. And so we want to make sure we respect patients' beliefs and preferences. There's some people that do not want to receive blood products. And so we have that usually on consents as well. So when you're witnessing it, after the patient signs it, they sign saying, yes, they consent to this. Then we just go, this little thing assigned below, and we just sign our name. And it's not saying that we went over it with them. We're saying the patient has said, yes, the doctor talked to me about it. I understand, and I consent to surgery. Fahim had a really good question on the break, is what happens if a patient can't write, right? Maybe they're quadriplegic and they can agree and they can maybe even speak, but they can't write. Well, in that case, we do verbal consent, and that requires 2 nurses. So if you can't write, so I would come over and say, hey, I have a patient who can't write. Could you do verbal consent with me? And we both independently, we would make sure you understand. And then we would just write verbal consent and we would both sign our names with our license after it. Yeah.
What about like if they're like, oh, my husband can sign for me? It's like a big limit, right? Or like,
I mean,
this-
if they're capable of signing,
Yes.
if somebody is maybe impaired, if some, right, and somebody is maybe developmentally delayed.
Right.
And they have an appointed caregiver or a power of attorney,
Right.
they can sign for them. But if it's at all possible, we ask them to sign. And a lot of times, guys, I just say it's policy. I'll say, oh, I thank you, I mean, I appreciate you wanting to sign, or you, them, but really policy just says if you could sign. No, if you could just sign, you know, and so I let the facility and the policies be the bad guy and not say like, you have to do this. It's like, I wish I could do, I just can't do anything about it. Oh, okay. So I want you guys to do a little bit of group work for a minute. So thinking about all the things we talked about, let's say you're the nurse that a patient's coming in to have surgery that day. I want you to develop a checklist. So think about all the things you want to make sure that you ask them about or you've talked to them about. So let's just take a couple minutes, just kind of get into little groups. And we're gonna think like, to start naming, what are the things we want to check on? That's a checklist we would go over with that patient before they go into surgery. About 30 more seconds, we'll wrap up. Okay, all right, so now we're gonna write our pre-op checklist. I'm gonna go around the room and we're just gonna name some things and we're just gonna kind of go in order of our areas and we'll just see how we do. So let's start back of the room. So what did you guys come up with one thing from your checklist? Their medication history? Absolutely, I really want to know their meds. All right, moving forward. Verify, yeah, absolutely. Verify the patient. That's one of the first things I ask patients. I'm like, hey, I want to make sure we spelled your name right. We got your birthday right. Will you read it to me? And that way they're looking at it. They're telling me we're checking the bracelet together. But yeah, verify the patient. All right, in the front, what do you guys got?
Allergies.
Allergies, absolutely. All right, here,
Health history, yeah.
health history, yeah. And this is really important. Sometimes we'll do the health history first. And they're like, you know, I have high cholesterol. Or actually, usually they'll say something benign, like weird. And then I do their medication list. I'm like, hold on, you're on medicine for high blood pressure. You're on medicine for your thyroid. You're on medicine for gout. You're on medicine. And they're like, well, I take medicine, so I don't have it anymore. I'm like, okay, like you still have those diseases. They're just controlled with your medication. Okay, let's see. Did you guys have something? Yeah, that's so important. Are they consentable? Do they have a POA? Yeah. AO/POA. All right, let's see. Back in the middle table, you guys have anything?
Removing like earrings and wigs and nail polish.
Yes, yeah. We want to make sure we remove all of our jewelry, especially if it's metal, because some surgeries use cautery or electrical type impulses, and that can actually cause burns. I took out, did we talk about this already? A few weeks ago, I had a patient come in for surgery. We took out 17 piercings. I was like, oh my gosh, I'm sorry. Like, yes, they all have to come out. Yeah, so dentures was another quick question. So dentures typically do want to come out, but patients have a lot of strong feelings about dentures. Sometimes, grandma's like, I don't want anybody to see me without my teeth. And so usually they talk to the anesthesiologist. Once they're kind of asleep, they'll take out the dentures and then they put them back in before they're really awake. So that's a conversation to have, yeah.
Nail polish I know, but artificial nails, is that a thing? I know that was like on a quiz question, but I was like.
I typically just want one nail that I can check an O2 sat. If I can't get an O2 sat on a finger, where's a good spot to check?
So.
Ears, sometimes a toe. Ears usually good. Yeah. Nail polish will impede the signal, and so it doesn't give an accurate reading. But all you have to do is turn the little thing from this way sideways, and then you can get a good reading too. Either way. Okay, so we said remove jewelry and accessories. Okay, let's see. Were you guys part of that group? We were separate. What does your group have?
Family history of past surgeries.
Yeah. And I would say it's kind of up with the health history, but I think it's true. We want to know family history and then past surgeries. One thing that's really important to say with this is that past surgeries, I want to know not only what have you had done, but how did it go? Right? Some people have what's called post-operative nausea and vomiting, where they just really react to the anesthesia and they have a lot of nausea and vomiting for sometimes days after the surgery. If that's been the case for them, we want to try to do what we can to prevent that from happening again. So the anesthesiologist might kind of tailor some of the medications they're giving them to be less nauseating. We might give them some additional medicine to help with that nausea. We're going to do what we can to prevent that. Let's see. Let's move into the back table. Were you guys in two groups or one group? Two groups? Okay, let's start with these guys over here, this half. Yes. Who's your person? So I'm gonna say DC ride. Yes, so important.
That designated discharge.
Oh, discharge. I'm so sorry. DC is discharge. Yeah.
Oh, yeah, I knew that.
Discharge. Okay, and then this half of the table over here. Yeah, what's their baseline, right? Because if they come in and their blood pressure is a little soft, it's like 96/52, I might be like, oh, what do you normally? And if they're like, that's my normal, I feel okay with that. Yeah. I think so. I hope so. Yes, I did. Bless you. Do you want to watch this? Who's asked that? Do you want to watch it again?
No, I just thought if there was someone connected, so I
Yeah,
didn't want it to feel like they're not, like it's paused or whatever.
Oh, okay. Yeah, no. They're good. And if you do join a recording, just so you guys know, if a Zoom is happening and you join it, it will say this is being recorded and you have to acknowledge that. So at least you're not like ever getting recorded without like knowing. Ooh. Okay, let's keep going. Let's see. I think we're back to back corner of the room again. Anything else that you guys had on your checklist?
Oh.
We'll take turns. Oh, I'm sorry. How about we'll open it to anybody? Let's see. Oh my gosh, so many hands, you guys. Okay, we'll go 1, 2, 3, 4. Okay. Yes, we want to know last PO, and I usually want both solid and liquid because usually they'll say no solids in your stomach for about 8 hours and no liquids. Usually you can have clear liquids up to 4 to 6 hours before surgery. So important. Okay, and how do they feel? That's totally. Yeah. Yeah, how are they feeling about it? Let's see, I think.
So I know meds is already up there, but we wanna know your medications on file, if you've actually taken them for that day.
Last time they took them, yeah, so meds with last dose. Right, because if they're taking a blood thinner, if they're on warfarin or Coumadin, I wanna know, when did you last take it, when did you stop it? Hopefully it wasn't yesterday, hopefully it was a few days. And then, yes, last void, so important. Do you guys know, when do we want people to void after surgery?
Is it like 12 hours? 6 hours. 4 hours.
There's still a number we haven't said.
Well,
Eight.
8. 8 hours is the standard, because remember, opiates can cause you to have urinary retention. And so typically the standard for all the hospitals I've ever worked at, 8 hours after surgery. And sometimes people are a little dehydrated, they just don't have to go. But usually when you come to them with a big old pulley, like, okay, we're going to do this if you don't go, then they're like, okay, I'll go. And they're able to go usually pretty well. But 8 hours, we always mark down when the last time they voided, because we don't go 8 hours from surgery. We go 8 hours from the last time they voided. So usually you have to go right before surgery. Question or another? Oh, okay, I think Alex was first, and I'll get to both you guys. If they, yeah, there's smoking and drinking history, so important. You know, if somebody is an alcoholic, for those of you guys who don't know, ETOH is ethanol alcohol, and so a lot of times you'll see that in the system as like that's like drinking alcohol. So if you see somebody's like health history and it says ETOH, use or abuse, like it's talking about alcohol. Yeah, we want to know if they're gonna start going through detox or something afterwards. Yeah, and then you guys had one?
Educate.
Educate, yeah.
Explaining
What do we need to teach them?
happened,
Here's
what's gonna
here's an
happen
incidence
after.
parameter. How do you use it?
Just like what we're gonna take before the surgery, how it's gonna play out, the time, just over explaining what's gonna happen this second, and after. And after.
Yeah, for sure. For sure. Yeah. Negative pregnancy test. Yes, any of those tests. And one thing I will note too, if you are on some medicines, like we think about our heart medicine, sometimes those can cause some electrolyte imbalances. We want to maybe do some of those tests the day of surgery. The doctors might say, I want to know what their potassium is today, just to make sure. Well, yeah.
Yeah.
And refusal of blood, right? If somebody, do you guys know what it's called if they don't want blood? It's not me either. What is it called?
They usually just have a blood. and no
It's
blood.
usually a band that says no blood, and it's called something in Epic. But it's like, it'll come to me probably in the middle of the night tonight. Anyway, it's called it, but oh, transfusion free. It's called transfusion free if you don't want to have blood products. And so then we have actually, most places have transfusion free services that they go through and they work with patients and say, especially if you're a high risk, you're having a hysterectomy or a surgery, we might expect a lot of blood loss. They might say, let's work with you, you know? Sometimes patients are okay with receiving their own blood. So they might even work with them and say, hey, we're gonna set you up so you go donate blood that's earmarked for you so that it's there the day of surgery. And then if you need a transfusion, you can get your own blood. So there's a lot of like timing and planning that goes into that. Yeah, Shalom, did you have one?
Oh, I was gonna say, skin prep, 'cause I know.
Yes. Oh, I love that you did that. So skin prep. So most people have to do a special, skin is with one. What, like a type of special soap or shower to use before coming into the hospital. It's an antibiotic usually type thing. So Hibiclens is a really common one. You can get it over the counter, like this pink soap. And they usually have them shower like the night before and when they come in. And when you come in for surgery, now if it's your wisdom teeth, right, you might not have to do this, but for most other surgeries at surgery centers or hospitals, they're then going to have you wipe down with usually CHG wipes. And they do that because they really want to make sure they prevent infection. At the hospital I work at, we also do little nose swabs as well, that it's got like this alcohol preparation thing that you swab in each nostril because germs like MRSA and other things like to live in dark little caves that are lovely little harbors for them. And so if we can kind of, you know, we're not getting rid of all of the germs and all of the bacteria, because we all have a lot of good bacteria on us. We're not getting rid of all of it, We're just kind of decreasing it overall, so that helps prevent post-op infections. The swabs, by the way, are not bad at all. They just go right in your nose a little bit and they smell like oranges, like I think that kind of thing. Anybody have any last things to put on our list?
Instructors, you know.
Yes, which I think would go really well with our POA. Yeah. All right, let's check ourselves. How do we do against what Davis's list was? Ooh, okay. ID band on, NPO, pre-op teaching, informed consent. Oh, did we get that one on there? Oh, we missed it. Okay, informed consent. That's one we got to make sure we get. History and physical on chart. So the provider who's ever doing the surgery, they have to write out or type out a full history and physical. That's a requirement for surgery. That kind of ensures that they know the patient, they know their health history, they know all of those things. Allergies, any lab results, ECG or EKG. We didn't put that one up there. And that would just be specific for patients that have maybe a heart or cardiac history. Sometimes they want to do an EKG the day of surgery, not always. Chest x-ray if needed, showered or bathed, hospital gown on, preps completed as ordered, anti-embolism stockings or compression hose or TED hose. For certain surgeries, especially those total joint replacements, they want those anti-embolism hose on before surgery. Now the leg of, right, if you're getting your knee replaced, they're not going to put they're going to put the one for the affected leg on after surgery. But you put the unaffected leg, you do that one before surgery. Let's see, jewelry is taken off. And I love how it puts here this position. What that means is if you took it off, where did you put it? Right? Because if they've got this antique ring that's been in their family for decades or generations, and now we lose it, that's a big deal. So we always want to document, you know, jewelry removed and given to husband, or put in container and placed in bag, whatever it is, we're just going to document, because otherwise, oh, I hate to lose those things. And it happens. Valuables, wherever they go to, dentures or prosthesis, hairpins, wigs, makeup, nail polish, one acrylic nail removed, one acrylic nail. It's more just making sure this patient like has all the excess off that they need. Contact lenses. So yeah, most patients will have to take out their contact lenses. So part of our pre-op teaching, if they wear contacts, we either encourage them to wear their glasses or bring them with them.
So one of the questions for homework, it was like, remove wig, artificial nails and something else. And that's the correct answer. Then artificial nails, wig, and there's like some other one that was obvious to everybody, but. Okay.
Yep, yeah, and if they have artificial nails, you just want at least one off so you can hook up your O2 step monitor to it. We're gonna talk about it when they voided, baseline vital signs, pre-op medications, their IV was started, where their eyeglasses and or hearing aids are at. Old chart to OR, okay, well, we all have usually computer charting, so we can access all the charts. Family location, next of kin, and then always the time they're ready for surgery, because usually you go in and you have to say, this is when I started working with them, and this is when I'm done. So you guys got most of this. I think you should give yourself a little hand. Well done. Holding area just means like when they come in day of surgery, right? We're going to verify this checklist. We're going to put an IV in them. They might get an antibiotic with us. It might be with anesthesia, but typically patients will get an IV antibiotic as a preventative to prevent infection before surgery. Here's our intraoperative phase. So this is inside the OR. It's usually a lot more busy with that because inside the OR, you have the surgeon. Sometimes you'll have the surgical tech or two assisting. You'll have a nurse in the room that will be circulating. Sometimes you might have an LPN that's assisting as well, working as a surgical tech. It just depends where you're at. You'll have an anesthesiologist. You might have an anesthesia tech. Like there's just a ton of people that end up in the room. So once they come into surgery, you want to position them because you can see from this bed, there's like no rails or all these things. You have to really make sure they have all these positioning tools and wraps and things that keep them safe. What to expect. And then everybody in surgery has special either gowns, if they're scrubbed in, if they're sterile, or wearing sterile gloves, sterile gown. If you're just part of the crew, like you're the circulating nurse, then you'll just have to wear like special scrubs the hospital provides. They don't want to bring anything in. But everybody will be wearing a mask and some sort of hat too. Good question?
Other aspect of his role during surgery in the OR.
So it depends on what you're hired as. You might be somebody who's like working almost like a scrub tech, like assisting the doctor, handing instruments and supplies. You might be helping like circulate, which means like, hey, like they need this over here, I need to go get this and kind of round things up.
What's in the hospital?
They can, yeah. Yeah, it's, I mean, OR is pretty cool. Ask Alex, our sim guy, he worked in the operating room for a long time. So if you ever want cool operating stories, he's got them. Oh, look at this, the LPN role. So just like we were talking about. So anesthesia, just a quick thing with anesthesia. It can be given in a variety of ways. We can do general anesthesia where they are completely out, right? They have no awareness. Oftentimes we stop them from breathing and we breathe for them. There can also be local anesthesia. So think about epidurals or things like that, where just block, sensation to a certain part of your body. This is endotracheal tube. I think you guys should have seen this before. Like you guys talked about trach care a week or two ago, right? So in tracheostomy, that's where this same type of thing, but it exits out the neck. An endotracheal tube can still go into the same place right above the lungs here, but the opening is through the mouth. Most patients will have an endotracheal tube during surgery or some sort of device that will protect their airway. Malignant hyperthermia, I'm not going to touch on it. We won't be tested on it. Just know it's a rare muscular disease and it has to do with how your body reacts to anesthesia. So that's one of the things we ask about family history. Let's say, anybody have a bad outcome from surgery? And they'll be like, yeah, every once in a while, some of my people just die from surgery. You're like, oh, okay, well, we probably want to check you. They can do muscle biopsies and check to see if they have it. There's treatments for it. We're not going to go over it. Just know it's a rare disease and surgery is screen people for it. Spinal anesthesia. Oh, here's the OR, a little more hopping. It's hard to see kind of what's going on here because this really is kind of what it looks like in an OR. And you have probably the provider, an assistant, and maybe a resident or intern, and who knows what this person is. Over here, this is the patient's head. And there's the anesthesiologist. Because the anesthesiologist really is like in their own little world. They are only focused on the breathing, and they've got their machines that will say like what their vital signs are, and they've got their medicines. They are totally removed from the surgery. Their focus is on the patient and how the patient's doing. After surgery is done, you go to PACU, right? So post anesthesia. This is very similar to what a lot of PACU areas look like. You wheel the patient in and you hook them up to the monitors. You make sure they're doing okay. And then once the patient is stabilized, they go to discharge area. Sometimes you'll have LPNs in the PACU. I think a lot of times they're mostly in the discharge area. One thing, when somebody's in the PACU, patients' family members are always worried. They're like, how are they doing? So you want to make sure before surgery you ask, can I let the family know how you're doing? When surgery is done, can I call somebody? Because that's part of what you would do if you were working in the PACU, is that once they're stable enough, you give the family a call and you say, hey, they're awake, they're doing okay, they're still a little groggy, but we'll probably move them over to discharge area pretty soon. Something, but we want to make sure we get permission. Otherwise, we're violating HIPAA, right? If we call and we're just like, hey, I saw your friends on Facebook and I want to let you know. So discharge criteria. When can you leave PACU to go to recovery? Well, you've got to have vital signs that are stable. You've got to be able to keep your oxygen sat over 90, right? That's a very low bar. But you got to keep it up a little bit. You have to be awake. You can be a little sleepy and drowsy, but you have to be able to be awake, maybe talk a little bit. The respirations aren't depressed and there's no active bleeding. So it's not really a lot. It's just we're making sure they're stable. They handle the anesthesia okay. Typically, patients are only in a recovery room for maybe an hour. It's just making sure things are doing okay. And then they go to recovery area. When you move into recovery area, this is kind of some basic stuff you guys talked about in foundations, right? Wherever we transfer anybody, we want to make sure we give a nurse-to-nurse report. Like you guys talk about transferring patients in foundations. Okay, nurse-to-nurse report. You tell them what's going on. You want the bed at the lowest position. You want the bed rails up. You want to give them their call light. Half the time they're sleeping and they don't remember, so you want to be checking on them. And then we want to be helping them. Like if they've got to get up and go to the bathroom, anesthesia can make them really loopy, right? We want to say, hey, don't get up. We want to make sure you sit up first, make sure you're okay, sit here for a bit, then we stand up and then we walk. So we're gonna be working with them. They'll need a lot of care. So if you think about patients who normally, maybe you take care of, this big group of patients, you're probably taking care of a much smaller group of patients in a recovery area because they need a lot more care. They need a lot more hands-on. Okay, which of these does the nurse implement to prevent post-operative respiratory complications for patients? And it's a tricky question. So yes, deep breathing and coughing and a sense spirometry. We talked about like how we answer these questions. Those are like obvious correct answers, right? But think about respiratory complications. Not only pneumonia, I'm also thinking about blood clots, right? So if we are having them ambulate early, if we're having them move their legs in bed, do those gas pedals and things, that's going to increase circulation and help prevent blood clots. So that could also travel to our lungs, right? So that's why those two answers are correct. Moving through. We're running out of time. Here's an example of a stapled incision. Okay, dehiscence and evisceration. You have a bit, this is regarding abdominal surgeries specifically. Dehiscence, I like to say, dehiscence means it detaches and evisceration is escaping. That's how I remember it. So dehiscence, either your staples or your sutures have pulled apart. Not good. Evisceration is you've had dehiscence and your bowel is now protruding. Really bad. Okay, so if that ever happens, it's a post-operative complication of abdominal surgeries. It doesn't happen as much anymore because so many things are done laparoscopically. So thankful for that. There's a couple things that we need to know. What do we do? So we put them in low Fowlers. Actually, before we even talk about this, you just think about how, like, trying to cut those intestines back into shape, right? So we're not going to be like upright, moving all around. We're going to have them in low Fowlers, have their knees flexed a little bit. So kind of giving a nice little like soft area. Usually you want to get their like sterile dressing with like moist with like saline or something, because you don't want that bowel, like right, our bowel is normally like all slippery and gooey. And so we don't want it to dry out. So we put some like saline with sterile gauze on there. We want to call the surgeon right away. In fact, I'd probably be like, stay here, I'm grabbing this, you go call the surgeon, right? Like we're going to be getting people together. We definitely want to monitor them because they could be going into shock, their bowels are sleeping. They might need more fluids and we want to get them ready for surgery right away. So I mean, I've never seen this happen, but I also see lots of test questions that pop up and NCLEX and other things. So I always make sure you guys know dehiscence is which one is dehiscence? Which one is evisceration? Yes, dehiscence, detaching, evisceration is it's escaping. Yeah, going out. Okay, when can you go home? So if you're gonna go home after surgery, you have to have stable vital signs. You can't be actively bleeding. I don't really think no nausea and vomiting, but it's controlled nausea and vomiting. Some people just have some nausea, especially I always tell people, you get in the car after surgery, you very well could get nauseous because that car ride and that motion just makes people a little bit more nauseous anyway. You wanna make sure their pain is controlled, they voided. Again, no dizziness with upright, it's manageable, right? It goes away once they've, stabilized themselves. And they have to have a responsible adult. Every once in a while, somebody comes in, they're like, no, my niece is gonna take me home. And then the niece shows up and she's 16. And I'm like, okay, well, let's see who else is available because we need an adult. Yeah. Oh, yeah, gotcha. So discharge from PACU, like it's a recovery room is also what PACU is sometimes called. That's after surgery. That's making sure they've woken up from surgery and they're kind of like doing okay after that anesthesia. Then they're moved to the discharge area. The discharge area that's where they're like, you're monitoring their vital signs, you're still checking them, but you're getting them ready to go home. So you're going over discharge instructions, making sure they have everything ready to go home. So it's different phases of care. I know, it does sound kind of funny. I guess maybe where do they transfer might be a better way of saying it, because PACU is definitely a higher level of care. You know, usually you have maybe 2 patients in PACU because you really have to pay close attention to them, make sure they're doing okay, and you only have them for a short period of time. But because anesthesia can have a lot of complications, surgery can have complications, we just want to make sure we're taking real good care looking, because if they're going to have a complication, it usually will happen right after surgery. So that's why we could keep a real close eye on them. And then once we're like, okay, you're good, now I'm going to transfer you to the discharge area. Yeah, it just depends. Some patients, if it was a real light sedation and they're healthy, they might go home after an hour or so. Other patients, it might be hours until we, get them all ready to go home. Yeah. All right, so moving on, because I know we're getting so close. What do we include in our discharge teaching? You totally could go. Totally fine. All right, for our discharge instructions, yes, we want to say what to report to the healthcare provider. Like, if you notice this, what's significant? We want to give instructions in writing, and we want to give instructions. We actually have them sign them. And usually we have the loved one sign it. We say, hey, I just want to make sure. And usually when they're signing, it's just saying, yes, I've been informed of my discharge instructions. Sometimes it also will say, I've also got my stuff returned back, because we want to make sure that we gave them their stuff. And I've had patients call afterwards and go, I didn't get my phone. I don't have my phone. And I'll be like, I remember we put your phone in the car. Did you look at the back seat? And then they'll go be like, oh my gosh, I forgot. And so you want to make sure they sign for it too. So in case there's any questions, we know. We want to teach them how to take care of their wound. They need to rest. When you've had anesthesia in your system, there's no driving, operating machinery, anything like that for 24 hours, and when to follow up with the doctor. Inpatient is almost the same. Okay, so really, really quick, big complications after surgery: pneumonia, developing blood clots, and I mean, infection and bleeding. Anyway, I'm skipping over this because we're going late. Oh, one thing I do want to make sure we know too, with treating pain, we often think medication, but I want to remind you guys that positioning is a very powerful tool, right? If you had surgery on your foot, elevating it, help decrease some of that swelling, can really help with pain. If you had shoulder surgery or back surgery, how you position the upper part of your body can greatly contribute to their pain level. So please know that we're not just giving pain medicine. We're giving position, we're giving ice, are giving medication. About it. Okay, that's pretty much it. All right, so I didn't get to go over the case study, but it's that one that was on the University of Maryland site. So it's a really good one to study, because I think it does give you a lot of like prioritization and how do you answer those questions. So you can go in as many times as you want to look at those case studies. If you have questions about the answers, let me know. I'm happy to help walk that through with you, but I think that's a good one to review in preparation for the test. Okay, so next week is the final. You're gonna do great. I believe in all of you. Make sure you do that discussion board, write your final. It's gonna be like worth 5% of your grade. So follow the rubric so you get full points for that. And then just really quick, before you take a test question, what's the first thing that you're gonna do? You're gonna read the question. You're gonna look for it, read through the whole thing. You're gonna pick out keywords. Then what are you gonna do? You might say like, what's obviously wrong? And then also, what is this question asking me? Go through that process and that will help you. I'll post it on an announcement later. So as you're practicing this week, you can use that to help you. Okay, thank you guys so much. I appreciate you. Yes, so the study, I'll put another study guide for the post-op, pre and post-op care. But I would go back through and look at the other study guides for the other chapters. Yeah. Yeah, and in your chapters, look through the objectives at the beginning and the summaries at the end. Those will really help you. You're welcome. Thank you. Thank you, Bethany, if you're still there.
Oh, that's.